I'm really excited to introduce our next speaker, Anuj Kapilashrami. And Anuj is an interdisciplinary social scientist and a professor of global health policy and equity, and director of global engagement and partnerships in the School of Health and Social Care at the University of Essex. Her work lies predominantly in the intersections of health policy and also development practice, with a particular interest in the social and structural determinants of health, which we have heard quite a bit already about, and the rights and equity implications of global health policy, health systems, and public-private partnerships and governance. Her current research examines migration as a structural determinant of health, where she adopts an intersectionality lens to reveal how intersecting gender and other social inequalities shape experiences of health, access to health, and also social protection and gender violence. Her passion and commitment to human rights and social justice informs the long-standing associations with the People's Health Movement in India and the UK, but also other civil society initiatives and leadership to knowledge exchange and capacity building initiatives for researchers and practitioners. She serves on the board of the Health Poverty Action as gender and rights advisor for the Department of Reproductive Health and Research at the WHO, and is the founding chair of the Migration Health South Asia Network. She is an active member and chair of MedAct, a nonprofit network of health workers for health justice. And her talk will focus today on migration, precarity, and health from a gender and intersectional lens. The floor is yours, Anuj.
Thanks so much for having me here. And I'm sincere apologies for that very long introductory note. I take full responsibility because the email that you did shorten it a bit, great. I didn't, but I did find an email in my spam box asking me to look at this profile. So I take full responsibility. In very short, I'm an academic activist working on health equity and social justice issues. And I think that would sum it all. Sincere apologies. I also want to say I'm delighted to be here and I'm super excited being part of you, despite a lot of challenges.
If you want to walk around, please take this microphone.
Excellent. Okay.
Yes.
Yeah. Okay. Despite a lot of challenges, including being pulled out of the immigration counter last night, because the Schengen visa I had, the name, apparently the number was shared by a man in China, and his face was coming up as I was crossing the border, so I was pulled out. So it has been a series of interesting experiences, but that hasn't dampened my spirit. I am super excited to be here, and part of the excitement is to be part of this panel. Some excellent talks, and you've already experienced that, and you've already heard that this morning. The other part of my excitement stems from seeing some old friends here from the UK, and a few of you who I've met earlier, both in the academic and the non-academic sectors. And thirdly and lastly, it is about just these engagement and interactions with public health institutions and talking about structural determinants of health and social determinants of health in public health institutions, which have had a legacy of practicing imperial and colonial medicine, is heartening, and it feels like the health inequalities movement is coming of age. So that is particularly heartening. So I would, without further, I think I'll probably stand. This is a bit more distracting. Standing here. So the previous speakers have done my job for sure very easy. I'm not going to go into a lot of data on health inequalities. The case for looking at health inequalities has been made, and has been made very beautifully and eloquently. The problem has been clearly established. What I am going to deep dive into is a particular dimension of health inequalities and focus on migration as a particular determinant of health, as well as a determinant of health inequalities. The backdrop to this talk is, as we have seen, that COVID-19 was a very stark reminder of health inequalities. We became aware as we were experiencing the pandemic that we're not all in this together, and we do not all experience this, the pandemic, the exposures, the morbidities, the impact on our social economic lives and political lives was not shared equally. And there was a disproportionate burden by populations which were at the intersections of, sorry, yes, I realize I'm not moving around.
Henry?
Yes, okay, if this helps, yes.
Because your voice is beautiful, but it's not strong enough to reach China and other parts of the internet.
Yes, okay, I will make a note of that. And so we knew that certain populations that at the intersections of multiple disadvantages, and I'm using that term consciously because I'm going to focus on intersectionality, and I'm going to come to that in a bit, did bear the disproportionate burden, and this was from a range of communities. But I'm going to particularly focus on migrants and refugees, where, for instance, ban on movements within countries, across countries, the closure of borders, both across countries, but also both state borders as well as and intrastate borders, closure of factories, working sites, and suspension of transport at very short notices that we experienced in large parts of the world, led to millions of migrants stranded, making journeys back to their villages or across rivers or across borders, out of work and starving. So there have been very clear instances of migrants dying on making their journeys back home. Just in India alone, there are about 10 million migrants who were out of work and had reported and experienced food insecurity. So what we also know from the pandemic is that it was not, is that the pandemic was just merely showing a light, but also intensifying some of these existing and entrenched social inequalities in the world, but also intensifying some of the existing stereotypes around particularly vulnerable population groups such as migrants being carriers. So we have, some of you who have been studying this area would have observed and seen reports of migrants being doused with, in a very inhumane manner, with disinfectants as they were making their way home, not having any relief or safety measures put in place, not transport provisions, which did come in many countries, but came in very late. So this kind of, and there were clear instances where migrants were seen as the problem. So the public health measures were being intensified for certain population groups, migrants or in detention camps, etc. And the same universal safety measures about distancing, washing hands were also being introduced in camps which were in extremely crowded situations or in resettlement areas and these crowded spaces which migrants inhabit. But what we also know is that pathologizing migrants as carriers of and vectors of diseases is not something new, and has been common to public and policy discourse. So if you go back to the work of HIV and AIDS, we know the bridge communities, the high-risk population groups, and how targeted public health interventions have impacted these populations, and often also increased the vulnerability in these contexts. But what COVID pandemic was distinctive in doing is turning our gaze to the contexts and the precarious situations and the intersections of the socioeconomic disadvantages that these migrants were experiencing. And I feel that has, and as someone was saying, that COVID-19 and the pandemic has been a living experiment. And I think there's been more attention subsequently to talking about inequalities, but also to talk about what is distinctive about precarious contexts and contexts of precarity that influence these vulnerabilities and or agencies. And I'll come to that in a bit. So that's what I'm going to focus on. That I'm starting those 3 points as a premise to the talk. I will be talking a bit about introducing the concept of precarity and precarious contexts of migration, and especially of migrants that I'm going to focus on here. And I feel talking about precarity is important because we've been talking about what public health already knows about the risk factors, about the determinants, but what it doesn't know is the mediation or the pathways through which these risks are produced. And I feel that's a biggest shortcoming of public health as today. And I'm not suggesting that none of the research is looking at those pathways, but we stop at risk factors and the proximal risk factors, not the distal, the causes of causes. So conceptual frameworks like precarity allow us to do that, but there are other frameworks as well. I'm going to talk a bit about the migration health scholarship and where it is. And the only reason I'll be introducing that is to just sort of reflect on some of the gaps around what we do not know and what we know and why knowing in certain ways is a problem. Again, responding to some of the questions that have also come up in the morning. I will be introducing intersectionality very briefly. I'm not doing a full, if you're interested, a short plug is I run a week-long intensive module on health inequalities and intersectionality 101 in January. So do attend that if you're interested more to hear more and learn more about its applications. And finally, just introduce very briefly what the transformative potential I see in intersectional applications. So just to start with precarity, a sociological concept that has been developed and suddenly became very popular also with Guy Standing's work on the precariat. So focusing on a particular class of population which is causing instabilities in society today, and a class which is experiencing, can be characterized or marked by significant insecurity. What I find very helpful for a recent paper that I have worked on is precarity, which Judith Butler talks about as a politically induced condition in which some populations suffer from failing social and economic networks of support and become differentially exposed to injury, violence, and death. Again, going back to the political determinants of health and the causes of causes, which are resulting in the risk factors that public health is attempting to understand and address. So in this paper, what I've highlighted is, and again, I'm just thinking a little bit about not all migrants were experiencing the kind of vulnerabilities that we are going to talk more about today. And not in the same ways. Migrant itself as a category is a very homogeneous and large category that includes very different patterns of mobility. It includes, if you start looking at bibliometric analysis and reviews that have looked at scholarship on migration, we're talking about international students, we're talking about expats, we're talking about migrant laborers, or economic and political, economic migrants, political refugees. There are a number of these administrative labels that help the work of public health, help collect the right kind of data, etc., but are not particularly useful in mapping the particular vulnerabilities that each of these categories are experiencing, or also the heterogeneity within each category. So just reflecting a little bit on what was about precarious contexts and migrants in precarious contexts that would allow us to understand the health implications better, we identified sort of 4 dimensions of precarity in this paper. And the 4 dimensions, the first is work. I mean, those of you who have been familiar with this concept of precarity and insecurity know that the concept has been extensively researched in the context of labor migration. So there's been growing attention to the concept in recent decades. However, it has largely been understood and historically studied in relation to the insecure labor conditions and relationships and the insecurity and hierarchicalization that it was creating. Then what sort of risks, so for example, occupational risks, contractual employments, insecure work, the nature of work itself was what was defining precarity. So in this framework, what I'm trying to do is go beyond just looking at work, because then in the context of migration, we are only talking about labor migrants. Even that category itself is limited in understanding the different determinants of mobility, different risks and exposures. But what it allows us to do in this migration context is also go beyond work to also look at social, economic, and political lives of migrants and people on the move. Right. So the 3 other dimensions that we started analyzing was to look at the migrant status-based precarity, which links to the nature of just being a migrant, the transience, the temporality that is associated with being a migrant, the fact that you may not have a permanent residence, you may not have access to documentation or the cards, and you may have very different access to healthcare because you're not only contributing to the economy at the destination site or state or a country, but you also have these links back home in villages or in other countries, depending on if you're looking at international versus the internal migrants. So transience itself leads to this precarity. And in this framework, we try to also identify the associated conditions and characteristics. Transience is also linked to illegality or to the social and biopolitical exclusion that some of the migrants face with healthcare or social care provisions. A third category that we look at and identify in the context of precarity is the social locations and identities. Acknowledging that migrants themselves is not a homogeneous category, and the experience of the so different aspects of social locations, such as gender or ethnicity or caste, disability, sexuality, would have, and the interactions between these would have an influence on how how migrants experience access to healthcare, the health outcomes, or even access to other entitlements and provisions, or what their vulnerabilities to abuse and exploitation in an entirely informal economy is, and how it is determined. So I'm going to talk a little bit more about the intersectional social locations in a bit. And finally, a fourth dimension of precarity links to the policies, governance, the informal regulations that are determining or limiting and enabling the experiences of access to healthcare and experiences of the entitlements in society. But again, some of these I'm going to talk a little bit more about. In this framework, besides highlighting the dimensions of precarity and what the associated conditions are, I also started looking at what's through a systematic, through a scoping review and content analysis, looking at the evidence around the pathways. So what do these conditions, what's health these produce, and through what mechanisms? But again, this is a framework that is derived from, and I'll show the full framework in a bit, but it is derived from work largely based on looking at evidence around what we know in migration and migrants' health, which is again very limiting because, and also skewed because there are only certain kinds of research being done in this field. So let's look at what precarious context we're talking about and in the context of, and where I am speaking from. My research in migration and migrants' health spans that whole framework of destination, this sort of the starting point, but also transit migration. So there are, and also acknowledges that these sites themselves are interchangeable. So often destination is not destination, but becomes a transit. Sometimes, for example, what we saw in the EU corridor and some of my research in Serbia and looking at how the open corridor was closing as Serbia wanted to accede to EU status, what that meant for migrants who were only transiting, but then were made to stay, and that became their destination, and through a series of biometrics, which would then limit them or their movement outside Serbia. The biometrics allowed the bordering countries from Hungary and Bulgaria and other parts to send the migrants back to their original destination. So those contexts are ever changing, but one particular context that I also speak from an SSR-ESRC study on urban transformations is the context of precarious work and living. So migrants contribute to it and are employed by an informal economy. In the context of South Asia and in India, Bangladesh, this 70 to 80% of the informal economy is inhabited by migrants, and they're often the street vendors. They're working in dhabas and restaurants, in factories. They've also taken on roles of tanning, working as factory laborers, but not on the payroll. Sometimes home-based work, women employing the domestic work sector, the care economy. So there are all these informal economy sectors that they're working in. And these are the kind of settlements that they are living in. Very temporary, some sleeping under flyovers, others almost 10 to 20 families, including about 100 to 200 individuals sharing the same compound as that of a villa or a next door bungalow is. So these are some pictures from some of the more recent work in India. The second aspect that emerged very clearly was both access and vulnerability as well as resourcefulness being very strict, tightly governed by and determined by the intersections of religion, came very strongly in the context of India. But also when I study the new migrants in the UK context, in Scotland and in England, ethnicity became a prominent axis of disadvantage, indigeneity, caste, gender identities. And just going back to some of the question that was being raised, not all of these identities were equally important in all contexts, and it is the formative work that allows us to understand which inequities and which axes of disadvantage become important. And the final bit was around the governance and the complete invisibility of these migrants in registers, in welfare and entitlements, yet the visibility that is rendered as COVID strikes and as thousands of these migrants are walking on the streets. The visibility again emerges, they become more visible in urban planning and gentrification efforts when certain cities have to be gentrified, so the whole population groups tend to be moved in the outskirts. And also visibility through the public health interventions and targeted programs. And I will touch upon some of these issues in a bit more detail later. And the final, the emphasis on precarious context is looking at migration in the wider context of a neoliberal restructured political economy, restrictive and very tightening border regimes. So we are seeing across the world restrictive asylum policies, very inhumane border fencing and patrolling. I mean, there's, I think this example from the borders in Hungary and Croatia. There are dogs that have been awarded for keeping migrants at bay in some of these European countries. So you're seeing a tightening of these border patrols and very stricter regulation of movement. There are also privatization and outsourcing of these movements, bilateral agreements being entered, like the very infamous example of the UK government trying to negotiate with Rwanda to outsource its migrants and limit the entries. And there are certain sort of pushback operations. There are also other sort of state regulations and regimes that are emerging, such as the Citizenships Registration Act, which is a process of unmaking citizens and making citizens stateless, making people stateless. So there's plenty of these examples, and this one happened just at the time where we were studying migrants' access to healthcare, the health outcomes experienced by migrants in the state of Assam and in a few other states in India, where a massive exercise of deregistering citizens was undertaken, which actually rendered millions of people stateless. So this is the kind of restrictive environment that we are looking at migration in the context of. That's the full framework. I'm not going to go into in depth, but just a framework to which is almost like a conceptual framework that is now being tested. And again, I'll invite other people who are studying this area to look at what measures can be identified to understand disposability, to understand work and income insecurity, to understand disempowered states in the context of work, or to understand the impact of surveillance on the kind of occupational health and other social determinants of health, such as sort of poor nutrition, food security. So how do we test a framework and gather evidence, something that the global burden of disease and the exercise that we're thinking about, including social determinants, will be helpful to also start thinking about the mechanisms and the states of disposability, insecurity, etc. these are producing. Just to very briefly introduce you to some of the gaps that this work and the number of different migration health research projects through Migration Health South Asia Network, as well as as well as some of the other GEMS and NIHR programs that we are trying to address. A number of gaps, and the scholarship field is really troubled by this sort of similar and the generic problems of knowledge production that someone was alluding to. But then there are also very specific areas, like an overemphasis on the administrative categories, the demarcation of refugees from migrant workers, with the understanding that refugees are not contributing as laborers or as in the economy of these countries, or having categories that are not indigenous, not understanding the specificities of migration. There's an overemphasis and influence on cross-border migration because migration became a crisis when it hit Europe and other high-income countries. That's not where the largest migration migration flows are. So countries in Southern Africa, in the Middle East have been contending with a lot of migratory patterns and movements and housing migrants from the bordering regions. But just not acknowledging the specificities of that migration pattern. For example, the internal migrants in South Asia become such an important category which tends to get missed out from a lot of international migration work that's being done. The second was the disproportionate focus on infectious diseases, again, fueled by the idea of migrants being vectors and carriers of disease, or even mental health that was being then studied primarily for refugees and asylum, in the context of refugees and asylum seekers. A third gap has been the research and policy disconnect, which is fueled by a number of different factors, not alone the global inequities in knowledge production. Most of the work, and we've been doing bibliometric analysis and scoping and systematic reviews, and the patterns are very clear that most of the work around migration is being produced in the north, and the sort of global migration health policies that are being developed are then being transported nationally and locally. So just those global inequities impacting on the agenda, which we are trying to address through the Migration Health South Asia and a very large program of work that has been initiated to review policies, to identify knowledge gaps, but also build capacities in research to address these knowledge gaps. A fourth is this whole emphasis on vulnerability. And when we start looking at women migrants, it is largely to do with sexual violence and abuse. And I've written previously in the context of Syrian conflict, but also more recently about the gendered nature of migration and why migration needs to be understood not simply between the difference between the men and women's experiences or risks and exposures, but also understanding how gendered is migration itself, the process, the conditions it creates, as well as the sort of new gendered structures that are getting formed as people move across. Something I'll address in a bit. And the final missing piece is which is also a challenge of migration scholarship more broadly, not just migration health scholarship, which is fairly nascent, is that historically the archetypical migrant has been a male migrant laborer. So we did not know a lot about which sectors women migrants and now the sort of queer communities and trans communities are moving to, where they're employed, what are the vulnerabilities they're experiencing. A lot of women's movement and feminist scholars have talked a lot about how traditional explanations for men's migration cannot be applied to women, and decisions to migrate are made within a larger context of gender interactions and expectations between individuals and within families and institutions. So just to expand on what those gendering migration what our attempt to gender these migration health debates lead us to. Firstly, that the process of migration itself is gendered, that is distinct norms, codes, and practices around gender and sexuality are shaping who migrates, under what conditions they migrate, what exposures and what risks they are exposed to, and with what implications does that have on their economic, social, and political lives, right? And second, the impact of migration on their socioeconomic political lives is also distinctly gendered. For instance, migration within and across borders is creating very different conditions. Possibilities for men and women, as well as the trans communities, opening up different sectors for employment, and also they're different at different stages of their mobility and settlement, whether as they're transiting, whether they're settled migrants, new migrants, migrants who have been in this particular context for say, more than 20, 30 years. And these also shape differential responses to policy as well as institutional responses. There've been a lot of scandal around the reproductive health rights approaches in Ireland and particular policy responses based on who's migrating, whether they're worthy of being considered or welcomed in those countries. This was something that was very clear in the workspaces that we started charting in the context of the India study. The sites were distinctly gendered. Labor chalks or labor crossings where migrants stand early morning to be picked up for different chores and to be absorbed in the informal economy of that particular context were distinctly male territory in one state, whereas in Assam and Guwahati were mixed, although with the significant number of women were segregated to certain spaces and picked up for certain kinds of jobs. Women, there were also distinct gendered codes governing the decision around what jobs they were being picked for. And also what we found was the women in particular were concentrated. This is just from that study, just a breakdown of some of the survey results that we conducted. What we found that women income was very critical for migrant households. They're not the other or marriage migrants who are moving simply because along with the male labor migrant, but also the nature of work dependent on the household's social economic position. But what we did find was women were concentrated in less organized, remunerative work, domestic, construction, home-based work. Within the same occupation, we found women earn much less, more frequently, as I said, not on payroll, and had fewer opportunities to upgrade their skills or progress with time. Much of the work that they undertook was invisible and in some cases also hidden from their partners. The other aspect, which was very common, was in all cases, women were also balancing reproductive and household and community roles in addition to contributing to the economy, their productive roles. Work burden became a recurrent theme across all the sessions, and the picture I have here, we also undertook some participatory action research work, including with photo voice, which was also in the cover photo of the presentation. But that also emerged that where women themselves would talk about how their work was unvalued, invisible, and earning them very small amounts for very long hours of work. Because home-based work, they became part of an economy where where certain kinds of factory work was outsourced. So this particular state is known for its factories, its leather goods, leather goods and the sort of raw material that is being made for soccer companies internationally. And much of the sewing of the football was being done in this household, in family context. And it earned them nearly 50 rupees, which is half a pound for each ball that they sewed. So there were longer hours. They were clearly more prone and exposed to problems around reproductive health, which also led to STIs, as some studies of home-based work have revealed. So what a gender lens allows us to bring to this debate is to start moving away from just looking at sex disaggregation and risks and outcomes based on men and women. But what I am arguing for is a contextual understanding of gender in migration. So looking at gender relations, how these are affecting motivations, the types of migration, patterns, processes, impacts and outcomes in sending, transit, destination, context, and as they move circularly. What we also find is that migrants are aware of this relational and contextual nature of gender, and they attempt to fulfill these expectations of identity and behavior that may differ very sharply in different places. So they are navigating spaces and processes like migration, which is bringing them both freedom of opportunity, introducing women to new work sectors when they were not allowed to work in their village settings or in other contexts, breaking free from some patriarchal controls, but also exposing them to more vulnerability, more violence and abuse. And the abuse is not confined to domestic space and homes, but also by the system. So constant exploitation, harassment from the states, that the vendors experience from their employers, but from also the landlords, where they were evicted at the time of COVID, as soon as the lockdown announced, all the bags thrown, etc., and they were out on streets. So there's been a lot of system-wide violence that they experienced, which often gets reduced to only looking at the sexual violence or the experiences of trafficking and abuse as in the context of migration research. Now, I'm just looking at time and we are doing okay, fine. So I will now introduce the second concept alongside precarity, or what I really am urging to adopt for health inequality studies. And I'm not the only one. The previous speakers have talked about intersectionality, so it's been used and it's been referred to. And I do not want to make this a class, but it is important to recognize where the historic origins of intersectionality. The term itself was coined by the American critical legal race scholar, Kimberly Crenshaw, who was critiquing the tacit whiteness of the women's movement, that how exclusionary women's movement were, because they were only representing sort of white middle class classes, and also the labor movements, and the sort of race movements, which were not including women or sort of understandings of gender. So the idea that is that the concept and the idea that challenges our belief that our social relations, our experiences, the exposures to risks, and our vulnerabilities can be experienced as separate roads, and also an idea that is challenging universal expressions of oppression and disadvantage. So even within gender studies, the idea that there were whole debates around the COVID pandemic when it first broke out about what the risk factors are. And the three risk factors that emerged initially were age, sex, and comorbidities. And then there was a counter argument about, we're saying men are more vulnerable, but there are all these additional burden that women experience. Intersectionality is trying to move away from this male versus female sort of making it about male versus female exposures and vulnerabilities, but it is moving towards understanding the different experiences and differential experiences, but also of both oppression, disadvantage, as well as privileges. So intersectionality allows us to look at that multiple layers of advantage and disadvantage that is structuring our everyday lives. I mentioned Kimberly Crenshaw, but I would, as the person who coined the term that has become very popular in the health inequalities and inequalities literature. But I do want to acknowledge that it has a much longer genealogy and has been influenced by Black, Latina, South Asian, Indigenous, and queer activist scholars. In South Asia, for example, there have been very strong caste movements and Dalit feminists who have talked about looking at, who have challenged these universalizing claims of feminist movements, but also emphasized these complex processes that are shaping human lives and creating oppression, injury, and oppression, inequities, and privilege. Intersectionality in a nutshell, I mean, I've introduced in so many different conferences, I've talked about it being used as a methodology, as an analytical and a conceptual approach, as a tool. But in essence, and what my more recent writings on intersectionality has been talking about, is it is just a lens and a political tool to conceptualize and act on social inequalities. And if you're applying this lens, we are applying it not only to look at the risks, but look at how problems themselves are framed. The importance of looking at the syndemic approaches when we talk about mental health and violence, looking at how the risk factors are interacting for different health conditions that we are seeing today. But this particular infographic is from the International People's Health University, and on my talk on intersectionality. And they really talk about what it is doing. It is making us rethink the ways in which we approach health and health, taking it beyond a biomedical construct to talk about psychosocial model of understanding health and its determinants. So a lot of scholars have written about intersectionality and what is intersecting. So there are identities and categories of social location. We've talked about those in previous work on data, in the previous presentation on data as well, gender, ethnicity, sexual identities, disability, and so on. But also the particular strength of intersectionality is how it links these individual social locations and positions with the processes and institutional policies and the forms of oppression that we are seeing today at both macro and micro level. Those causes of causes that are actually determining the differences and the unjust and the avoidable differences in health and health outcomes today. I'll give some examples of some of the applications that I've been involved in, but just very, very quickly, what intersectional approach is moving away from is rejecting a hierarchy of vulnerable groups and universal conception of their experiences. So it is important that, and I think Michelle said that we do need to do the homework of what that hierarchy is, who are most vulnerable in one particular context and setting, how are disadvantages operating and panning out. The second is showing risks and impacts are shaped by a web of factors, but looking at the interaction of these factors. Gender and race cannot simply be looked at additively. It needs to be looked at, the interaction of these two need to be looked at simultaneously for us to be able to understand the processes and the mediation effects of producing certain inequities. And third, as I said, allowing the individual and group levels to look at, to be connected with the social processes. This is from a policy brief that we did on COVID as it hit, and urging people to move beyond just the sex disaggregated discussion around COVID. But what this requires really is to move beyond sex disaggregated data or data on single axis of disadvantage. And the challenge with adopting an intersectional lens is data is very limited. So the question of, do we not know this? We probably do not know all the factors that are affecting it. And these debates in different countries are fractured along different lines, right? So work that I'm doing with an Innovate project with looking at mental health, inequities in mental health burden in Essex, working with integrated care boards. We do not have data to report on migrant, on whether they're new migrants, the ethnicities, or the generation we are talking about, or even basic data on which is sex disaggregated. We have excellent indicators around the deprivation indices, compounded indicators around the SDI, the deprivation index, to assess sort of the cumulative understanding of poverty and the disadvantage. But we know that there are additive effects of ethnicity and race over and above being concentrated in those deprived areas. The second is collecting and contextualizing that data. And the third is then undertaking that intersectional analysis, not only of that data to understand how are these inequities being produced and what are the mediating effects, but also policies and interventions to identify and prioritize those most at risk. And finally, in terms of interventions, to also move beyond a deficit model to simultaneously talk about resourcefulness, resilience, and of agency. So just, I'm going to in the next, so in the next sort of 5 minutes, I'm going to talk about just a few applications of an intersectional lens that I've been involved with in researching inequalities in health determination. These are 3 projects. The first was based in Scotland, but I was more of an participatory action research and an attempt to build the people's health movement in Scotland. And this really led to a number of very positive system-wide changes, both in sort of ensuring accountability, in using public hearings as a tool for accountability in NHS Health Scotland and among others. But this was really looking at how multiple disadvantages interact to produce differences in access to health enabling resources. And this was a fairly long process embedded in social movements and people's health movement that we were able to, that was successful in both sort of in some policy environment change as well as in contributing to the particular marginalities of these specific populations. The second was in response to the COVID pandemic and the excess burden that we saw among health workforce, excess burden of mortality among health workforce during the COVID-19 pandemic. And as the previous speakers were talking about, those differences were initially brushed off as genetic, the ACP receptor genes impacting on and predisposing them to higher risks. Some even referred to different therapeutic cultures of care, that some of the South Asian minority ethnic groups are coming closer to patients and giving care and hence being more susceptible. So this sort of triggered this particular study that I led a team of, we call it ICOPE, Intersectional Analysis of COVID Protections and Exposures, and through a survey which was looking at experiences and workplace factors that influence their vulnerabilities and perceptions of risk to COVID-19 infection and mortality. And what the study evidence was very clear was that ethnic inequities were found across several workplace hazards, with increased exposure to, less protection against infection, more responsibility for clinical management of infection, and also of evidence of systemic racial bias in the disproportionate redeployment of minority ethnic nurse, and in particular, this was more prominent among the nursing staff, to COVID-19 areas, to front-facing roles. And more recently, there's been a lot of, and UK REACH study has done a lot of work around the ethnic exposures, but this was way back in 2020. So we know that these systemic racism and oppressions exist in systems, and there is evidence now to suggest that, but there are reports that have denied any occurrence of racism in NHS and in other systems in the UK. And the final piece of work, which I've recently launched, is this Global Health Research Group on gender violence and mental health, where we are studying the syndemics and exposures to both mental health and gender violence, understanding the mechanisms, both socioeconomic, geopolitical mechanisms underlying these the burdens and risks among migrants, but both through quantitative survey methodologies, longitudinal surveys following migrants as they move across borders, but also through more participatory approaches. I'm going to skim through this because I've already talked about the results of this, but we undertook an intersectional analysis in the health workforce study to actually see what is informed, and did not take a homogeneous migrant category. We tried to break it down into, or ethnic minority category. We tried to break it down into the generation of migrants, where the health workforce had done their training, what sort of citizenship. We, of course, because it was a survey of about 600 practitioners, we did not have power enough to actually then disaggregate based on the different ethnicities, and had to fall back on the BMing categories that the UK government follows. I'll now summarize this, and just to talk about just drawing lessons from the different research projects that I have talked about, is the transformative potential of intersectionality and utilizing that intersectional lens in health inequalities research. Conceptually and empirically, it allows for intra, and anti-categorical approaches. So not only looking at inter-categorical differences between two sort of sets of different populations, rich and poor, but also breaking them down within those categories. So within migrants, what sort of different categories emerged in this process. It allows us to move beyond determinants and risk factors to the process of determination, to the upstream drivers that is determining these risk factors that public health is measuring. And also challenging, I think, to me, some of the studies that I've been involved in is actually also unpacking the ways and the framing of the problem and the narratives around the migration health crisis. How do we frame the crisis? How do we frame the different categories of migrants? And when we start looking at which categories of migrants are being addressed in policy responses, we start looking at what their different as social locations are, what ethnicities, what religion, and what other factors are determining which migrants are actually welcomed by states and which migrants are left to starve with the sort of and with poor health outcomes, or to be bitten by dogs on border fences. Final transformative potential is really the methodological of what, if we combine surveys with participatory action research approaches, with qualitative approaches, how does operationalizing intersectionality also influence and create an action agenda with affected populations towards social change? And this is an ongoing process. We have achieved some successes working with sort of integrated care boards where intersectionality is now being adopted in their strategies, but that's a long way to go in addressing and in really tackling the inequities problem we see today. Thank you.
Thank you so much, Anuj. Now, let's see, are there questions? I'm sure there are. Oh, I already see a hand up. Okay.
Hello. Yeah, that's straightforward. Great. Hello. Thank you very much for that presentation. I have a two-part question where the second part is the real question. You mentioned Assam. That in Assam, they had a more gender integrated approach than other parts that you saw in your study. And so the first part of my question is, do you think that that is because Assam is more tribal and so they have different kind of underlying social norms that came into play that would affect how the interaction was? Which, if so, leads to my big question. If you're able to say anything on the interaction between the culture of the migrant community and how it interacts with the majority culture to then interplay in all these factors. Yeah, it's broad.
Wow, a fascinating question, really important one. I don't think I'll be able to answer it fully. I mean, I wouldn't make a generic comment about the gender. I was basically making a reference to the two sides, which had which very clearly were very different in the gender performativity in these labor crossings, the intersections of labor crossings, where laborers would accommodate. At the same time, we did see that there were more women in certain workforce as compared to in Jalandhar, which was basically had migrants from particular communities in Bihar and UP in the sort of very, in states with lower socio-demographic profiles, low resources. And there you found stricter social controls for women, where women were more in home-based occupation, outsourced by these factories and other employment. Whereas you're absolutely right, the Assam, the community, the migrants that were also coming from were not just these other states, but also from the different states in the Northeast. And a lot of women, indigenous women, would sell and be on the streets selling sort of indigenous produce, some of the forest produce, etc. So you did see a lot more engagement of women in workforce and more visible workforce, not simply in domestic care home sectors or in care economies and stuff. What was your second question? You'll have to repeat that for me.
If you could generalize that generally, how minority cultures interact with majority cultures. I recognize it's very.
Yes, and that is challenging, and in fact, that also forced us to start looking at the categories of migrants and even the terms that international research on migration is using, because there are so many colloquial terms that are used for migrants in different contexts. In Pakistan, there are also official names, like migrants are officially called aliens in some countries. In others, you find the connotation is linked to the religious bias versus the ethnic bias. So there is a very interesting site of contestation with the minority and majority culture. Migrants in most cultures are seen as, and I'm talking now even more generically, even looking at what we have seen in the UK, what was the sort of partly the basis of Brexit, was the story about migrants stealing our jobs. And that is universal as far as our research has seen, whether it is in the context of the transit and the EU corridors or in South Asia. So you do see a lot of everyday and day-to-day violence that they experience from local communities. At the same time, a reliance and dependence on migrant communities for sustenance of these households, middle class and upper middle class households. So it's a very tenuous interaction that we have seen. So they become objects of charity and benevolence in the households that they are being employed. At the same time, you find them being excluded from sort of benefits that employers would provide to their employees and so on. Also, very clear instances during COVID in the domestic sector, for example, of forfeiting the migrants having to forfeit their wages that had been accumulated for over months because they were seen as these sort of vectors, carriers of disease. So they would not given their wages. They were also treated badly. I mean, there was very clear instances of abuse and harassment. And at the same time, we have seen experiences where in domestic work, again, that was a safety net or a sort of social security because the employers were able to support them for the months that they were unemployed. So, I mean, there have been both kinds of processes that were very common. I hope that answers your question.
Thank you. We have two more questions, and after that, I would probably wrap it up in the interest of time. You go ahead, and then. There's another one.
Thank you so much for your talk and your fascinating inputs. My question is about methodology and data analysis. So you talked about the need to use diverse kinds of data, and then in the last slide, you again underlined the importance of mixed method studies, participatory photo-voice elements, but also survey data to really understand the micro and the macro perspectives. Now, my question is, on a analysis level, how do you bring these different levels of analysis together in a way that it tells a story and kind of sells itself for a journal and a discipline? And how do you make sense of that mess across these levels of analysis?
So telling the story is not the problem. Absolutely not. I mean, in fact, all these data allow you to tell the right story and a full story. If you are pulling this data from both sort of the kind of survey results, there are always explanations that can be generated through both more, if you've collected the right kinds of data, and also if you have you've also captured the lived experiences from these communities. The challenge is always the target journals, where you publish what kinds of data. And I think there is a slight shift in several journals acknowledging, several public health journals also beginning to acknowledge that more diverse types of data is necessary. I've been at conversations with even with BMJ and in meetings with Lancet, etc., where they are keen to look at some of the qualitative data. We have had problems with, there were only select journals that actually would allow you to publish participatory maps of resources in the community. But then, those are not the only research outputs. You're not doing research only to have those 3-4-star publications. And this, I'm saying, cognizant of the kind of madness that has ensued following the announcement of Ref 2028 in the UK. But I'm conscious of that. But some of this work has been very useful in working with the integrated care boards and with the NHS health trusts in the UK. Just using this data, interactive asset maps that we have been creating with communities for health authorities to use in the area. So we're also thinking about slightly different outputs and different purposes of disseminating research.
Okay, thank you. One last question due to time. Other questions, please just approach Anuj after the meeting at the reception. So go ahead.
Yes. Anuj, thank you for your valuable insights into your work and for sharing your knowledge with us. My question actually takes kind of the same trajectory as my prior speakers ones, but maybe step more like before that. So I'd be interested, why did you actually decide to use participatory methods to work on this special topic?
Why? It speaks to the questions I'm asking. I introduced myself as an academic activist, and part of the research is to bring about social change. You cannot bring about social change and correct inequities without engaging people who these inequities are affecting the most. And that was so I did not even sort of think about that question until you're asking me now. But for me, the kind of questions I'm asking, some of them can be answered mainly by sort of qualitative research, some from participatory action research, and some require data. So I'm not talking about secondary data analysis right now. I'm talking about primary research with large-scale surveys and populations that we are following. I think that data is important. Understanding the burden of mental health in migrant populations and how that is changing as they move across space and time is an important question that cannot only be answered by qualitative question. So I feel it's important to think about what is the real purpose of the question that you're answering, the research you're doing, and then think about the methods and what will lead you to those answers. I hope I've answered that question.